You're tuned into Recovery TV, the voice of hope, with your host, John J. Tassoni Jr. Discussions and information on addiction and mental health issues. Here's your host, John J. Tassoni Jr., with today's guest.
Welcome to Recovery TV, and I'm your host, John Tassoni. Narcan, please get it. CVS, Walgreens, URI, please carry it. It saves lives. Overdose numbers, deaths are down. Overdoses are up still. But get the Narcan, it saves lives. My guest today is Dr. Larkin, the new Department of Health Chief, Director. What are you, Doc?
Head Director.
Head Director.
Yes.
Head Director.
Okay.
So welcome and thank you for joining us today.
Thank you.
So I want to give my viewers a little bit of background about Dr. Larkin and how you got to Rhode Island and become the chief.
Sure. Well, for the last 20 years, before being nominated by Governor McKee and confirmed by the Senate, I was primarily an infectious diseases consultant at Rhode Island Hospital, Miriam Hospital, Newport, Women and Infants. I was also in the training program for the Infectious Diseases Fellowship. So I was a faculty member at Brown University School of Medicine, and also had a practice as an outpatient caring for people living with HIV. And that's 20 years. I came to Rhode Island. My wife originally was from Pawtucket, related to the Pelagi ice cream family, but her last name is Farley. Yeah. And so we moved here in 2005. Nice job, returning to her roots with her extended family.
And now you stepped into a massive overdose problem in Rhode Island.
Well, I've become the director of the Department of Health, and certainly that's one of the priorities of the governor, of the Department of Health, of the BHDDH as well. So it's a whole of government effort.
You know, with the epidemic of the overdoses and COVID, it was like a perfect storm here in Rhode Island. A lot of overdose deaths until we started flooding the market with Narcan and trying to get that out on the street to save lives. We've lost a lot of Rhode Islanders because of it. What is the Department of Health doing to eradicate this problem?
So one of the things that we are really actively engaged in is the distribution of naloxone, so Narcan, which is a reversal agent. One of the 4 pillars of addressing the opioid epidemic involves rescue and harm reduction. So rescue, Narcan, also education about that. One of the real signifiers, or one of the real risks for a fatal overdose, is actually doing it at home or in isolation. So if you have a person who is there present when a person overdoses, then they can reverse that. Harm reduction involves actually creating a safe space where people can engage in use, where again there's going to be a trained licensed person available to assist them if they get into trouble.
What about, I'm hearing these new strains that are coming out. Are you hearing anything like that, new strains of this opioid, the fentanyl?
Right. So there's many different types of opioids. That's a general term used for that entire class of drugs. So it includes things like morphine and oxycodone and OxyContin, those types of things. Fentanyl is an incredibly powerful opioid. There's another related drug called carfentanil, which is generally used in veterinary medicine, so it's used for animals, is even more powerful than fentanyl. And this is one of the problems, is that people may use one opioid and then switch to another and not realize the potency of the drug that they're using. Another really troubling situation is if someone is in a period of recovery and then engages in reuse, they're also not able to judge the potency of the drug that may be available to them. And then thirdly is that the potency or the strength of any given drug. Of course, it's not regulated by the FDA or a pharmacy or anything like that. So the potency of a drug that might become available to a person on the street or otherwise is not really necessarily in any way regulated or measured prior to use.
Right. There was a lot of talk in the circle that we all belong to about the carfentanil and
Right.
the regular fentanyl. A lot more of the seniors now that we're hearing can't get the meds from their docs because of the scripts, the amount of scripts that docs can write. And then they were going to the street and buying these pills, these pain medication pills, but they weren't really pain medication pills. As we know, it maintains a lot of fentanyl in them.
Right.
These people making them, and and it bothers me to a point where not us, but the DEA and all the rest of the people can't sit down at the table and try to figure out the right amount of prescriptions that an individual can get. I know when I just had surgery in October, doctor says you only can have 8 pills and you go to extra strength Tylenol after that. Well, if something didn't heal right or got worse, I was in a quagmire.
Okay.
I talked to a lot of seniors, shoulder surgery, knee surgery, and they're only allowed X amount of pills. How does Rhode Island say, okay, listen, docs, we're not going. DEA is not going to come in and raid your office because you're giving out prescriptions. How do we help the pain patients? How do we help them?
So one thing is that if your pain is not controlled after a medical procedure, and you are finding that the pain medication that was dispensed to you is going to run out, I think you need to go back to that original prescriber, whether it be a nurse practitioner, physician's assistant, physician, to explain the situation that you're experiencing, not only just because of the pain that you're experiencing, but if you are having pain that's out of proportion to what the provider may have anticipated, then that may be, need additional examination by the provider themselves, by the person, sort of understanding, well, this person's in a lot of pain after this surgery, which is, I usually expect them to be in pain for a day or two and then things to be starting to get better. The presence of pain may mean that things are not healing well. So I think always returning to that original provider, that does a couple things. It allows the provider to know what's going on with you. Secondly, it allows the provider to understand that there are variations in people. And then lastly, they should still have full license to prescribe additional medication. There is a monitoring system so that we know if someone has gotten medications from one person or another person, or sort of how much they've received. So that provider can then access that system and sort of say, okay, this is what the person has received so far. I'm okay doing this additional prescription. One thing that will raise flags, if you will, is that if a patient is going to different providers and seeking different...
Seeker, yeah. I got to take a break.
Sure.
You're watching Recovery TV, and I'm your host, John Tassoni. We'll be right back after these messages.
And now, back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, AdCare. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, John Tassoni. Dr. Larkin is in the house, and he's a director over at the Department of Health. And Doc, thank you for taking the time out.
Thank you for having me.
I know I could get you out of the office for a little bit and get a little fresh air.
Yep.
But thank you for joining us today. I want to talk a little bit about the task force.
Sure.
Can you give us an update on what the task force is concentrating on moving forward?
So the Governor's Task Force was established in 2015. We have 4 pillars that are encompassed within the Governor's strategic plan. So it involves prevention, rescue and harm reduction, treatment, and recovery. And this work has been very important, and every year we go through a process of having proposals submitted for different types of work, whether it be data management, peer counseling, prevention, recovery. This is money that's available through the opioid settlement. And we disperse that into the communities. We look at metrics, we measure things, and then also every month we meet and we hear from different subject matter experts as well as from the community. It's a 3-part chairmanship. Myself, the director of the Behavioral Health, Developmental Disabilities, Rich Leclerc, and then we have a community chair as well, Alex Gautier, right now. And every month we sort of learn more and plan more about how we're going to work on recovery in Rhode Island.
Yeah, you know, it's ironic that all these meetings we're still learning. Still learning because it's not getting any better. The overdose deaths are down.
Correct.
But the overdoses, you know, over the past couple of weeks we've gotten alerts with different spikes throughout the state of Rhode Island.
Right.
What approaches do you see that the governor's task force can take to alleviate this problem? I know we're not going to eradicate it. The only way we're going to eradicate it is if they get rid of fentanyl.
Right, right. So one of the more innovative things that Rhode Island has done in the last 12 months is opened up Project Weber Renew, Harm Reduction Center. And this is a facility that is licensed by the Department of Health, where you have staff that can help a patient or a person if there's a problem with opioid use. So that's we are the first state in the country to actually license a facility. There have been a couple other facilities open, but none of them have been licensed. So that's a really important step. Another thing that we do is distribution of naloxone, Narcan. So this is a reversal agent, very important in helping someone who is getting into trouble with overdose. We also have different ways of connecting people to care. So there's something called BH Link. This is a 24-hour, 7-day-a-week facility at 975 Waterman Avenue in Providence that any person can access at any time to get a referral to behavioral health services. We've also recently started our certified community behavioral health centers throughout the state. That was in October, which really nests behavioral health in the community and is an important tool as well.
Yeah, I was having conversations with BH Link a couple weeks ago, and the amount of people that actually visit there, I was like astounded by how many people that they're seeing. You know, mental health is not going away either.
Correct.
It seems to be getting worse and worse and worse. I mean, is there any new approaches that the department is looking at for mental health?
Well, I think one of the issues is not so much that mental health is getting worse or that there's a larger epidemic. It's actually recognition and acceptance of mental health issues.
That's true.
So in particular, recently, June was Men's Mental Health Month. I engaged in a really moving Facebook event with Kasim Yarn, our Director of Veterans Affairs, and that was really focused on actually understanding men's mental health in particular. Men are less likely to seek or acknowledge mental health issues and have the highest rates of suicide, particularly in the sort of working years of between 35 and 55 or so. There's a program called You Good Man that we have rolled out that's running through June through August, and the hallmark of that is to actually encourage people to check in with themselves, check in with others. That's the sort of You Good Man, You Good Man. It's a question. And you can access that at yougoodman.org, where there's some videos and other resources for you.
That's good information. It's good information. What do you think the road from here on with the overdoses? Do you think the reduction of overdose deaths will keep going down? that we have more and more naloxone on the street?
I certainly hope so. It's not just naloxone, though. It's also safe use or safer use, in the, and then also, greater public awareness, both in someone who might engage in use themselves, as well as their family and friends. One of the things that is actually a continuing obstacle, but I think we're continuing to make headway with, is the stigma. So I was just recently in Portugal, and while engaging in distribution or sale of narcotics is still illegal, possession or use itself is completely decriminalized. They also have led the way in this idea of harm reduction centers, and they've actually gone quite a ways towards reducing their incidence of use, as well as certainly fatal overdoses and overdoses.
I think if we ever get to that point, we have to bring in the folks who take care of healthcare.
Correct.
Because now the legislature has legalized kratom. I have probably about a dozen people that are in treatment for kratom use throughout the state. And then the facilities are not getting paid for it. So that's something that if we go down this road, that we need to bring everybody to the table and say, okay, if we're going to do this, got to make sure they get paid for services rendered.
Absolutely.
And I always say this, Doc. I say, these insurance companies, obviously they're in to make money. But that being said, you can't just give someone who needs to go into treatment 14 days and then release them, and then they go back in for another 14 and back in. It's like putting a mouse on a wheel.
Yep.
If we're going to give them treatment, they need the appropriate treatment to get better. Because if they get better, then they can become productive citizens again, go to work, do their thing, and go home. Not just keep going in and out of treatment. We're going to take another break.
Thank you.
You're watching Recovery TV, and I'm your host, John Tassoni. We'll be right back after these messages.
And now, back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, AdCare. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, John Tassoni. Dr. Larkin from the Department of Health has been my guest today. Doctor, thank you for joining us today. I greatly appreciate you spending time and talking to us about the overdose issue. But I want to let the viewers know, too, about your website. Your website is phenomenal with information. If people, have any sort of questions about the overdose, epidemics that may be out there, infectious disease, it's a well-rounded website.
Thank you. I appreciate that. We have a great staff supporting that and doing work every day on that. I'd like to take credit for it personally, but I'll only take credit on behalf of them.
Well, I got to give them kudos, because every time I have a question that I don't know myself, I go right to the website, boom.
Very good.
Google it, and we're good to go. I want to talk a little bit about 988.
Sure.
Let's talk about 988 in Rhode Island. Obviously, this year, the legislature was almost to the goal line about putting funding in there for 988 moving forward. They have enough money for this year up until next June.
Right.
What are you seeing with 988?
So 988 is a great tool because it's as simple as just doing that. 988, just like 911. So 988, and you can have access to someone to talk to you about mental health issues, as well as link you to care. There's also a website. It's 988lifeline.org/chat. And it's a really important tool. Again, the idea is that there's no wrong door. We need to make people available or have availability, through any means that they access, whether it be BH Link, their primary care provider, the Department of Health, or 988. I'm optimistic that funding will come through again.
Good.
And that we'll continue that, because I think the work is very important.
Now, Doc, I want to thank you for joining us today. I greatly
Thank you.
Appreciate it. Next week, my guest is Derek Durian from Hope Recovery. If you see something, say something. See you next week.